Welcome to HMA's Vital Viewpoints on Healthcare, concise conversations with experts that identify practical solutions to make healthcare and human services work better. I'm your host, Jennifer Colamonago, and I'm thrilled to be your guide as we explore new ideas for solving challenges that confound our uniquely American systems charged with delivering health and healthcare. In a world that has far too much information and far too little wisdom, we'll aim to keep it simple. Frank conversations about what it really takes to reimagine these systems of health and healthcare. Our HMA experts know how things work and don't work, and they have viewpoints on both the problems and solutions that are born from that experience. Vital Viewpoints on Healthcare is not just another podcast. It's your window into the minds of those steering us toward a healthier future. Subscribe now, and together we will explore the hard-earned wisdom that could change the way you think about your professional challenges. Today's guest is Erin Russell. Erin is a dedicated harm reduction expert and a principal consultant with HMA, where she leads a portfolio of projects that expand the reach and acceptability of harm reduction practices. She's been immersed in harm reduction for over a decade, with experience in advocacy, government, nonprofit organizations. Before she joined HMA, she was the first chief of the Center for Harm Reduction Services at the Maryland Department of Health. She led statewide naloxone distribution, syringe service programs, a harm reduction grant program, and low capacity building initiatives. Erin's really been at the forefront of integrating harm reduction into larger behavioral health, opioid response, prevention programming, which improves state government's capacity to meet the needs of people who use drugs. Erin, I'm really glad to have you with us today. It's been fun getting to know you as we've worked together. Let's start with a basic question. What does harm reduction mean? I know that you work in this space and it's a common phrase, but some of our listeners may not be familiar with what this means. So talk us through a little bit about what it includes, and then I'd love to know how you got into this space.
Harm reduction, as you mentioned in my bio, has been a part of my life for 15 years. I've seen it manifest on 3 different levels. Harm reduction describes tools that reduce the immediate harms of using drugs. Then harm reduction is an approach. So by providing those types of services, we're acknowledging that people use drugs. We're removing judgment from that experience, and we're asking people what they need right now to be as healthy as possible, as safe as possible, and to determine for themselves the quality of life that they want and what they would like to pursue. And then finally, harm reduction is an approach to policy, thinking about policy. And I'll talk a lot about this when I talk to people about stigma of drug use. I believe a lot of the stigma stems from the fact that drugs are criminalized in the United States. Harm reduction as an approach to policy is trying to shift some of that focus away from criminalization and towards treatment, compassion, and kind of trying to maintain a sense of care for people rather than a punishment approach.
So how did you get started in this space?
I got started volunteering at a syringe service program in Pittsburgh, Pennsylvania. I went to college at the University of Pittsburgh and was trying out a lot of different fields. I always had an interest and knew I wanted to get involved in public health, but didn't know very much what public health was at the time. I took classes in a lot of different fields to get a feel for where I might fit in. As part of the Social Work 101 class, I was required to volunteer. I knew I wanted to do public health, so I asked around looking for volunteer opportunities in public health to kind of meet that requirement, thinking it would be a short-term box checked for this class. I got connected to the local needle exchange program. And once I started volunteering, I just then never stopped. I got so fascinated by this intervention or by this program, challenged me in a lot of ways. I think that's one reason I stay in this field is because harm reduction turns upside down everything you think you know about drugs. And it was surprising to me, the people I met, the people who came through those doors. I realized I was not much different than anybody there. And I just was amazed when I learned that that program only existed because of an emergency declaration in the city that allowed for the program to exist in response to the HIV crisis. So there is still to this day no state law in Pennsylvania that allows for syringe service programs to operate. That shocked me because I just saw how effective this intervention was.
Yeah.
I went once a week to the needle exchange program, sometimes twice a week to volunteer. I would sit down with people who came in and ask them what they needed that week. We had a checklist of supplies. I would talk through their patterns of drug use, if they injected drugs, how many times a day, what types of drugs they were using. And then I would have that conversation with them, check off the supplies, give that checklist to another volunteer who would bag the supplies up for the person. I'd also ask the person if they wanted naloxone. And if they did, I would connect them to someone, or I would provide the training myself and give them that kit. It's very simple. And some people come in and they just want to tell you that they need 100 syringes in this type, and then they're on their way. Some people want to sit down and say they've been struggling with a wound on their arm and they're not sure what to do about it. Syringe service programs are now in a lot of places offering wound care services, and they are often like that first line of interaction someone has with talking about their health and their needs. So anyway, the length of conversation and the type of conversation depends on the person and what they want to talk about that day. And then I saw lots of people get connected to treatment, tested for hepatitis and linked to hepatitis treatment. Again, all realizing that this only existed because of a very short-term response, or not a permanent law. And so for me, from a human rights perspective, that just seemed wrong. And it has continued to motivate me. I mean, a needle costs 10 cents and it saves our healthcare system a lot of money, and it saves somebody a lot of pain by not getting HIV or other infectious diseases that you can get. So there's a huge return on investment in these programs, and then just wanting there to be more equitable care for people who use drugs has really motivated me.
So we hear a lot in healthcare, this idea of meet people where they are. This seems like the kind of the ultimate version of that, right? They come in for one thing, but you have the opportunity to engage them and perhaps identify all sorts of other needs that, that they may have, health or otherwise. What is it you think people least understand? I think maybe you touched on it, but if you had to give people the 90-second version of like what they need to really get about this, what would that be?
I think what people least understand is the impact of drug policy on drug-related harms, that connection. Because we tend to fixate on the harms of drugs, that drugs themselves are the problem and are what's bad, when really drugs are molecules that have an impact on our body. In certain doses, they have different effects. People use fentanyl in a healthcare setting for anesthesiology, for the treatment of pain, particularly cancer-related pain. Fentanyl is a really important and valuable pain management tool. But when it's in an illicit drug market, when it's bought on the street, it's not regulated. It is unpredictable, the dose that you're going to receive. That relationship between making drugs illegal and the unpredictability of dose that people can then purchase, I think is one thing that is the least understood. I often say it's bad drug policy is what kills people more than bad drugs. And every overdose is a policy failure because we have not put into statute, put into practice, and really codified services and programs that support and care for people who are using drugs. The legal drug market creates a lot of risk for people who are involved in it, and that risk is expensive. That is like affecting the price and then the quality of drugs that make their way into people's hands. And there's studies showing the enforcement of drug policies has an effect on the quality and then the overdose risk associated with the drugs that you can purchase. When there is a drug bust, within a 1-mile radius, overdose rates increase within the 7 days following that drug bust. It has an immediate impact on the quality of drugs, people's ability to predict the drugs that they're using and kind of anticipate the effects. People are really good at identifying how much drug they need to use based on their tolerance levels. Tolerance plays a big role in overdose risk. So when the supply is unpredictable and they have to go to a different source, when that source is unknown, it then puts them at extremely high risk of overdose. So I find myself explaining a lot that connection between the macro level policies and then the drugs that people are buying in the street, and trying to show that a lot of the deaths we're seeing is because of an unpredictable, volatile drug market and the introduction of new types of substances that people's tolerance is not ready for. I think the other thing I want people to know is that, yeah, harm reduction really is the only evidence-based way to stop overdose deaths, that we could really end the crisis, the overdose crisis, if we invested in harm reduction to expand to its full capacity. Those evidence-based interventions are the expansion of naloxone that I mentioned reverses opioid overdoses. Getting it at arm's length of anyone who is going to witness an overdose is effective at decreasing overdose mortality. Increasing access to medications for opioid use disorder. We've seen that dramatically decrease overdose rates in cities that have really invested in low threshold access, reducing all barriers, particularly to buprenorphine. And then finally, supervised consumption. That is where we have a center that people can go to with pre-obtained drugs. When they use drugs, they're being witnessed. There's someone there who can immediately respond if there's an overdose. So those are the ways that we were able to expand access to those three interventions. It would have a tremendous effect on our overdose rates in a given area.
Thinking about the stigma as you've talked about it, I mean, that sort of threads through everything that you're talking about, right? I mean, there, you talk about supervised use and obviously I think it raises hackles even among people who might otherwise support, or you might be able to like intellectually get the data side, but like, it just makes me a little uncomfortable. And I'm sure that kind of gets to why our policy framework is more punitive. But I feel like we're tackling stigma in so many ways right now, right? The broader mental health issues. People are talking about things more. People are putting more of a human face on it. I feel like the opioid epidemic itself, and forgive me if I'm using that word incorrectly, but, just where we are with this kind of crisis level has been very humanizing, right? We've all probably experienced loss of people who have died, related to overdose. And so it's not sort of those people, it's our people, right? And do you see that changing? Do you see the in your work in harm reduction, is it kind of benefiting from perhaps a little bit less stigma on these issues more broadly?
I think we're reaching a tipping point. I mean, 40% of Americans have been directly affected by the overdose crisis. And the majority of those have felt that their life is forever altered as a result of loss or the trauma associated with this crisis. So you're right, it's affecting more people than ever. And we have more awareness. People know what harm reduction is in ways that they never did. And it's being talked about at the federal level in ways that it never has. SAMHSA just released a harm reduction toolkit. There's harm reduction being mentioned in the president's address earlier this year. So there is definitely an environment of unprecedented buy-in and resource allocation to harm reduction. Fortunately, I don't think we're at a point where we are fully embracing harm reduction. And I think that harm reduction interventions will always be limited in their impact in a context of criminalization of drugs. I can give a couple examples of how I've seen people be held back. I mean, I have a friend who served as an EMS supervisor, was looking at run reports and looking at notes and evaluating the call records and response records of his team. And when EMS treats an overdose, if too much naloxone is given, someone who is opioid dependent can experience acute withdrawal. And that is extremely uncomfortable. You feel nauseous, you feel like you have the flu, you feel really sick, and it can motivate people to try to do whatever they can do to feel better.
Counterproductive, I guess.
Yes, it's counterproductive, and it's not compassionate to put people into withdrawal. I personally think that could be one of the keys to ending the crisis, is paying more attention to withdrawal, and that if someone isn't in withdrawal after an overdose, they're going to be more likely to accept post-overdose care or be interested in learning more. And that can include getting a naloxone kit for themselves, talking to a peer recovery specialist, getting inducted onto a buprenorphine regimen, things like that. But what he noticed when he looked at those run reports was that they would code for withdrawal and then not code for an anti-nausea medication. And he asked them, like, why are you not treating the nausea? You're not treating the withdrawal? And they would say no. And he's like, why not? And they did it to themselves. And there's this thought that like people deserve to feel bad after they experience one of the consequences of drug use, as if it's their fault. So the thinking that drug use is someone's fault, thinking that experiencing overdose is someone's fault, is like baked in to our
Yeah.
consciousness. It has been years of a war on drugs, and it is perpetuated by our media, by articles that talk about people as zombies, the latest zombie drug, the latest flesh-eating drug, or even, associating some scary events that happen in society to drug use and kind of conflating the drug with what we're seeing as social problems. That has been our tendency for many years. And I think it's very, very difficult to undo while we're still in an environment of criminalization. The other example I heard recently about a patient at an opioid treatment program with cancer had showed up at the opioid treatment program seeking care and was experiencing some symptoms of a psychosis. And she had just purchased drugs from the illicit market and felt like she had no other option because her doctor would not prescribe her pain management because of her history of drug use. This was a cancer patient experiencing cancer-related pain, and she was not getting adequate care because of the doctor's judgment and or risk analysis for himself about what might happen if prescribing these medications. So the opioid treatment program then carried the burden of trying to manage this person's care and figuring out next steps. There is a difference in the way that people who use drugs get treated.
Well, you've talked about kind of decisions that are made at the point of care that negatively impact people in ways that are, maybe intended, maybe unintended, but maybe kind of go up a level to the policy framework. What are what are the areas that you are focused on in terms of changing policy, perhaps at your time in Maryland? What were you able to do at a policy level that kind of changed the environment around these issues?
The approach I took to policy was thinking that going back to kind of that 3 levels of harm reduction, tools, approach, and policy. So one, because harm reduction is underdeveloped in many parts of the US, we need first authorizing legislation for harm reduction programs, and then the investment in the establishment of just brick and mortar services. So we need more fixed site syringe service programs, more drop-in centers that are providing harm reduction wraparound care, case management, linkage to other services, low threshold treatments, infectious disease testing and treatment, et cetera.
Are those kind of new sites, or are those things that are sort of co-located either with like community clinics or opioid treatment centers, or is that sort of bringing the services to places that are already interfacing with the community, or are these kind of distinct, standalone, separate bricks and mortar?
Both. Yeah. So initially, I think we need authorizing legislation. I mean, Maryland, I worked on the naloxone access law that allowed anyone to get a prescription for naloxone, eventually a standing order that allowed anyone to get naloxone without an individual prescription. Naloxone is now available over the counter. And so that prescription's not necessary for some formulations, but not all. I worked on legislation that removed those barriers for anyone in the public to get access to this life-saving drug. And then I also worked on legislation increasing access to syringe service programs. So previously in Maryland, only the Baltimore City Health Department operated a syringe service program. Now there's over 20 across the state because of a law passed in 2016 by the Maryland State Assembly that allowed any organization or health department to create a program. So again, this is legislation that allows for the establishment of new programs, new services, and creating access points for those life-saving tools. And then kind of what you're talking about and what I think is a blend of the two, both new standalone sites with certain service programs. We really should take the word syringe out of them. I mean, they're just hubs of care for people who use drugs, and they offer much more than access to sterile injection equipment, especially as we see trends across the country away from injecting, and a lot more people who are smoking or inhaling drugs. And there's other routes of administration for which we have tools to provide people. Those hubs of care, again, I've mentioned over and over the infectious disease prevention component, but there's also case management, getting people enrolled in insurance, identifying coverage opportunities for them. Education is a big thing. Again, because we don't talk practically about drugs, and we don't provide transparent, clear, useful information about drug safety, often that is provided at a harm reduction program. And there's resources and educational materials for people to learn about drugs in order to reduce their risk of overdose and reduce the transmission of disease. So, and then there's policies that help to integrate that into other places. So we do see existing service providers integrating these services. I worked with Healthcare for the Homeless in Baltimore City. They're doing a great job operating a co-located, they integrated syringe access into their behavioral health treatment service area. And there's a lot of other examples about kind of the integration of these harm reduction services into existing places and how they've worked that into their workflow and system of care.
Yeah, I mean, that gets back to sort of the meet people where they are. I mean, it seems if you're trying to reduce stigma, bringing these services to the people along with other things that help them, be healthier or make better choices. It seems that that would, as opposed to, oh, you have to go to that separate place if you need that thing, right? And isn't that, it seems to me in the work we've done around just opioid treatment centers and getting the medicines, there's a little bit of that, right? We've bifurcated, like you have to go over there to get that stuff, and over here we take care of your health. But it's really all about your health. So, but that's a policy choice, as you've said, right? How do we wrap that in to our public health system and our healthcare delivery system?
Absolutely. And offering harm reduction tools sends a message to people. It tells people that you care about whether they live or die. It tells people that you are here for them regardless of their drug use status that day. And that's a very powerful message when people have been turned down, pushed away, incredibly marginalized because of their drug use. And we have seen over and over that service providers, providers that embrace the harm reduction approach, they see more patients. They get more foot traffic. They are trusted more by the community, and it leads to better patient outcomes, and it leads to better business overall.
Well, and I'm assuming also crime and, public safety. I mean, there seems to be like community benefit, right? If people are being better cared for. I mean, that there's all sorts of other upstream benefits for that.
Yes. Yeah, there's harm reduction interventions from other countries that are not yet implemented in the United States, such as offering different opioid agonists as forms of treatment. And that includes long-acting hydromorphone, diacetylmorphine. These programs are called prescription heroin in other countries. And they're offered like alongside methadone. So in a very regimented treatment setting, but it's diverting money out of cartels. It's diverting money out of that system. And people also engage in less crime because they're not having to, we see that behavior, that negative behavior that often that is a signal of addiction and accompanies addiction. We see that reduce because people have a stable, predictable supply of drugs. So it reduces overdose risk, it reduces crime. And that's true too, even for the services that we implement in the US, such as syringe services and overdose prevention sites, of which we have 2 in New York City right now.
Talk about funding a little bit. There's sort of like there's obviously the public health element to this. So, is this coming out of public health programs? To what extent is this coming out of Medicaid programs? Obviously, the correlation, perhaps, although not exclusively, right, with poverty. I mean, we see increased opioid addiction problems in the Medicare population, right? So it's older. It's more. It's not really only about poor people, right? It goes back to the everyone problem. But how are these services being paid for right now, even though it's affecting probably a wider swath?
Again, harm reduction is under-resourced. Traditionally, most harm reduction programs, syringe service programs, are funded through philanthropic means. They're nonprofit grassroots organizations that are fundraising and that are getting the majority of money from a foundation or other type of organization. There is a federal ban on using federal funds for the purchase of syringes. This is extremely limiting, and only recently, in the very, very recently, has the federal government allowed federal funds to be used for the operations of a harm reduction syringe service program. So anything but the syringe, so to speak. And the funding that's currently being used, that's federal funding, is mostly the state overdose response grants that are congressionally allocated for states to respond to the overdose crisis. So they fund a variety of things. So it's not long-term sustainable funding like Medicaid. There's a few harm reduction programs that have the infrastructure to bill Medicaid, and they do for certain services, but that is a pretty high threshold for a lot of the grassroots nonprofit, smaller organizations that are really embedded in the community and reaching people at high risk. There needs to be an investment to integrate harm reduction services. I mean, there could be reimbursement and coverage for more harm reduction services by providers already established and reimbursed by Medicaid. But then we need kind of an alternate, sustainable way to cover on the ground more grassroots services. The funding landscape for harm reduction is precarious. The Elizabeth Taylor, was very involved in HIV/AIDS activism and was a major donor through AIDS United for a lot. When her health declined, it was a scary time for harm reduction programs. It's only a few of those types of philanthropic organizations that are really funding the bulk of syringes. There has been more state investment. I was part of that in Maryland, of establishing state investment in services and braiding funding to cover all types of harm reduction services. We used a couple different funding sources other than federal to pay for syringes for programs. It is possible, but you have to be really innovative. You got to be really ambitious. You got to get a lot of buy-in and support. I think that there are probably more sustainable ways that the federal government and state governments could work in partnership to ensure that local programs and on-the-ground programs are really supported over the long term.
Do the opioid settlement funds create any opportunity here? I mean, obviously, those are one-time funds, so we know that's not sustainable, but does that provide an opportunity to at least get something off the ground, perhaps?
Considering that those funds are only here because so many people have died, and as a result of just this, we are continuing to experience an overdose crisis in which we lose over 100,000 people a year in this country. I think that money needs to go directly to grassroots and local initiatives and really support the delivery of services that make sense for a community. Harm reduction, as I've mentioned over and over, works. It is cost effective. It is life-saving, but it's not a one-size-fits-all. Community really needs to be involved in designing and implementing and evaluating the harm reduction programs that make sense for their community. It's very community-driven. I often say that the best response to drug-related harms in a community is one that's hyper-local. The drug market can vary block by block. I mean, especially in a place like where I live in Baltimore City, what's affecting the life of someone who is using drugs can vary city by city. And so it really needs to be driven by people who know the community and are trusted by the community.
A bottom-up approach, a grassroots kind of policy approach.
Yeah, and I think that it's only right that funding goes to support people who have been directly impacted by this, and to try to create an environment where we are simultaneously stopping overdose right now. And like I said, harm reduction is the key to doing that.
Right.
While we invest in the building of a more prepared and stronger and sustainable behavioral health system of care. And I think the behavioral health system was unprepared for the level of demand and the burden that has been required of it during the overdose crisis. I mean, we talked about harm reduction being a way to engage people who, again, are often not involved in care, very marginalized. Many people who use drugs are also experiencing an unstable housing conditions. And when we give someone a harm reduction tool, we're saying we care about them. That can help them to stabilize and think about what's next. It can help them to consider talking to you about what their needs really are, and it can help them get engaged in care. Evaluations of syringe service programs have shown that people who are regularly going to a syringe service program are 5 times more likely to seek and stay in treatment and seek long-term recovery. They have this touch point, and then when they want to make a major change, they do that and they're more ready for it and they're more ready to commit to it over the long term.
That's powerful.
Yeah, so I think to really make the most out of opioid settlement funds, harm reduction from that perspective is not just like a band-aid on the issue. It's really building capacity for community and building connection to a behavioral health system that can support people over the long term.
Yeah, it's like a mindset change that, the policy, the funding has to flow from that, but there's a bit of it's a culture change, really, hearts and minds, I think, that we're talking about.
Absolutely. And we see harm reductions kind of like niche, activisty, um, approach. And certainly harm reductionists are angry at the system. I am.
Yeah.
There's been a lot of harm from the way the drug war has been enforced. We say it's a war on people. It's not a war on drugs. It's a war on people who use drugs. People are the ones bearing the brunt of it, and mostly people of color.
Yeah.
We disproportionately enforce drug laws in communities of color, and it has led to mass incarceration of people of color, particularly men of color, and that has dramatically changed our society. So there are rightfully angry harm reductionists out there, and I think it's combined, some of the stigma where people see harm reduction as enabling, see it as, we just want it to be a free for all for everyone to just use whatever drugs they want, and it will increase harm if we do that. That often leads to harm reduction being seen as this one thing we do over here on the side. I hope through that perspective shift, people see that harm reduction it's just a way of thinking about things that can really infuse a transformation of our system of care, or it can really inform a transformation that just makes services more equitable, more effective, and makes people's lives better over time.
So if you had a magic wand, you've talked about a lot of different solutions, but if you had a magic wand and you could wield it to change one thing, just one, that would have the biggest kind of ripple effect on this whole area, what would that be?
My goal is to end the war on drugs. I could see the ending of the war on drugs in my career. That would be wonderful. The regulation of drugs so that people who use them have a predictable, understandable, and safe supply of drugs. And that if drugs make their lives unmanageable, they can seek treatment and not feel ashamed about that and not feel the level of stigma and shame that we feel now. I'm a person who is in a 12-step program. I consider myself in recovery, and I understand how that shame can hold people back from seeking care. I had to go through that myself. I do believe the criminalization is the root cause of a lot of the issues we see with access to care and stigma. So if I could wave a magic wand, that's what I would change.
That makes a lot of sense. Well, and your work is your way to give back, right? And continue to hopefully make the world a better place for people, the actual human beings that are experiencing this part of their lives. So thank you for being with us today and talking about your story, your experience, your commitment, your vision. I know there's a lot of interest and curiosity and increasing data behind these issues. So it's good to know that you're at the helm here and helping people make some better policy choices. So thank you.
Thank you. Really appreciate being here, and thank you for listening.
This episode of Vital Viewpoints on Healthcare is brought to you by HMA Grant Prospector. Is your organization looking for behavioral health grant funding? HMA's Grant Prospector is your ultimate solution to streamline your grant search time and maximize your grant seeking success. Get started today and unlock your organization's potential. For more information on the grant prospector, visit hmais.healthmanagement.com. Thank you for tuning in to another enlightening episode of HMA's Vital Viewpoints on Healthcare. We hope today's discussion has sparked new insights and perspectives. To learn more about our esteemed guests, please be sure to visit healthmanagement.com/podcast. Until next time, stay informed, stay curious, and keep searching for the wisdom that will help to transform our healthcare landscape. This podcast was produced by myself, Jennifer Colomonico, along with Tiffany McKenzie, in collaboration with our guests. The content is the property of Health Management Associates.